Hi, this is Heather Rosenberg. I'll introduce our presentation and then we'll get started describing oppositional defiant disorder. We'll give you a brief overview of what it looks like and then we'll talk about some of the typical symptoms and treatments. Oppositional defiant disorder shows up in the DSM-5 in a category that covers disruptive, impulse control, and conduct disorders. It's distinguished by a pattern of angry, irritable moods and argumentative, defiant behaviors or vindictiveness. Other disorders in the same category may have behavioral or emotional elements, but ODD has an evenly distributed criteria set between emotions and behaviors. We'll cover comorbidities in a couple of screens, but it's helpful in comparing it to ADD. So an ADD sufferer might impulsively push another child too hard on a swing, but would then feel sorry. Whereas an ODD sufferer might do the same action, but would deny it or possibly even brag about it later. It's diagnosed by noticing at least 4 specific symptoms, which we'll cover in a few moments, over at least a 6-month period, exceeding the frequency and severity normative for the age, gender, and culture. So for instance, the temper tantrums of a 2-year-old wouldn't qualify because that's normative for their age. The severity depends on the number of settings. If it shows up only at home, that would be a mild case. But if it shows up at home and school, or even a third place, that becomes more severe. It can't be diagnosed by watching a child with their sibling. It has to be a child to an adult in authority over them. The diagnosis is normally made through multi-informant information by a therapist. So the therapist makes the diagnosis, but there are multi-informants, teachers, parents, or others who make that recommendation. It's commonly diagnosed in later childhood or adolescence, and it's rarely diagnosed alone. We'll discuss those comorbidities in just a moment, but they're pretty consistent. There isn't one test used for diagnosis, which is difficult. So there's a series of other tests that can be used to help confirm the suspicions of the informants. These might be behavioral skills, behavioral observations, and functional assessments. There are some common tests that are used, which is the Child Behavior Checklist, the Child Behavior Inventory, the Stutter-Iberg Student Inventory, the Conners Teacher Rating Scale, but also others such as the National Initiative for Children's Healthcare Quality and the SNAP-4 Teacher and Parent Rating Scale, along with others. Oppositional defiance disorder first is described, if not defined, in the DSM-2 as they attempted to group childhood and adolescent disorders associated with delinquency, such as runaway reaction, unsocialized aggression, and group delinquency, what we would really call conduct disorder. But by the DSM-3 gets its own definition and description, which includes symptoms such as violations of minor rules, temper tantrums, argumentativeness, provocative behavior, and stubbornness. However, there was wide criticism of this definition because it suggested that ODD diagnoses pathologized normal childhood behavior, especially when conduct disorder aggression was not seen. So a revised definition was made, adding new behaviors such as swearing and also clarifying others. They also made a clear distinction between the normative behavior for an age group and noted the need for the behavior to continue for at least 6 months. By the DSM-4, there was significant progress made and developing clearer lines between the ODD and CD diagnoses, and a conviction that ODD was often a precursor to CD. We'll look quickly at minority implications. It's relatively consistent across countries that differ in ethnicity. There is a higher prevalence in Caucasians. While this is a weak predictor, it is a significant number. It also happens most predominantly in lower economic status families, but the complicating factor is that they can't always get testing or treatment for diagnosis. It is specific to the cultural context, so an ODD student in China may look very, very different than an ODD student in America. It's more common in males than females, but we want to note that most of the early children that were diagnosed or used for the diagnoses were males, so they are not confident, even in the DSM-5, that the diagnostic criteria would fit for girls.
There are many factors that contribute to a child developing ODD. The important thing to remember is that all these factors interact with one another and cannot be separated out. Many of the factors can be found within the actual family of the individual. Parental mental health, parenting styles, poverty, family conflict, poor parental supervision, and parental stress all contribute to one another. In the same way, environmental factors such as poverty and having married parents can lead into increased parental stress, which then leads to harsh parenting styles. It is important to note that being white and having married parents were significant factors, but weak predictors of ODD. A big factor is, of course, the mental health of the parents themselves, particularly maternal depression, if there's any substance abuse happening within the home, such as alcohol or other drugs, or if the parent has any antisocial disorders, then that all contributes to the child developing ODD. Research has found links to cognitive development with ODD as a factor. For example, poor sensory regulation, which is the ability to regulate sensory input, has been linked to ODD, similar to autistic children being unable to regulate their sensory input. Insecure attachment is, of course, also related again to parental stress and parental harsh parenting styles, maternal depression, all of it. Low effort of control, which is the child's ability to control their own emotions or enact control on their own emotions. One study found that an effort of control can be taught and increased, which then affected ODD behaviors. Low sensitivity to punishments and low conductive skin activity. They found that children with behavioral disorders have been found to have a lower basal skin conductive activity, making it harder for punishment or reward to be used. So, for example, they have less of a reaction to pain and less of a sensitivity to affection. So those are not working the same as they are with other children to be able to give punishments or rewards. The neurological factor is that the impact of the decreased gray matter density, how that affects things is that this part of the brain, the orbital frontal cortex, is tied to impulse control, decision making, impaired representation, and emotional control. Research has found that the neurology of children of behavioral disorders may inhibit them from learning behaviors in traditional ways, for example, through punishments or reward. Fahim wrote that, quote, findings suggest that thinning and decreased gray matter density of the insula disorganizes prefrontal circuits, diminishing the inhibitory influence of the prefrontal cortex on anger, aggression, cruelty, and impulsivity, and increasing a person's likelihood of aggressive behavior. So the changes in the neurology of a child with ODD has an effect on whether or not they are able to actually control how they learn and how they are reacting to the world around them.
As you can see, there are many symptoms those with ODD experience. Some of these symptoms include temper tantrums, excessive argument, angry attitude, distorted thinking, and mistaken assumptions, as well as revenge thinking. These are just many of the few listed on this screen. ODD is recognized when this behavior is consistent and not comparable to those who are around the same age. Another factor to consider while looking at ODD is the potential for other diagnoses to be present. Often, therapists see an association with ODD behavior and these listed comorbidities. Some include ADD, ADHD, anxiety, depression, and conduct disorder. These are a few of the many listed on this screen. Due to this, it is often difficult to recognize and treat ODD.
Trouble with treatment. Oppositional defiant disorder is often hard to diagnose, as it looks like a myriad of other developmental and mood disorders such as ADD, conduct disorder, depression, and anxiety. So oftentimes, you're either misdiagnosed as something else, or more often, the child is diagnosed with a comorbidity of disorders. So you can find treatment for, say, depression, but that's not fully treating ODD. So thus making treatment harder and least effective. Another issue with treatment is parental involvement. So a lot of times treatment doesn't even happen because the parents will seek to find treatment for a number of reasons, such as this is just a phase, my child's going to grow out of it, it's not that bad, or if there are socioeconomic barriers preventing them from finding treatment, that can also be an issue. And when parents do decide to find treatment, depending on the culture, there can be a lot of shame that comes with seeking help, especially mental health. And so you can get a lot of pushback from the parents. Since parental involvement is so huge in treating ODD effectively, if the parents are not fully on board with treatment, it's going to render treatment ineffective. Or on the other hand, you can have parents who are just dealing with their own issues and just finding it difficult to be able to effectively help their child. Treatments. So in a study with adolescents who have both depression and ODD, antidepressants such as fluoxetine and CBT therapy have been proven effective. We know that CBT therapy helps with cognitive restructuring. It helps to change the way you think, to change the way you react to things. And we know that antidepressants increase the serotonin in our brains. The research is still limited, and there hasn't been one proven effective treatment just to treat ODD by itself. If children are having trouble in school, they can be eligible for a behavioral plan. But first, in order to be eligible for a behavioral plan, they have to be eligible for an IEP, which is an individualized educational plan. That happens when the parent or the teacher or the school counselor notice that the student is struggling academically, socially, whatever way, and then they will come out, they will get observed by the school counselor, by outside psychologists and psychiatrists. The teacher will evaluate their educational levels, then they will have a meeting and figure out a plan for the child. Now, what an IEP does is help the child with modification. So if they need help, if they're at a lower rate in math, they're going to modify their work. If they get overwhelmed in the classroom and they need lots of breaks, they're going to be able to get lots of breaks. Or if they need to listen to music while they work because it helps their anxiety, they're going to be able to do that. So they're going to get different modifications that a quote-unquote normal student in a school would get. Now, if they're having trouble with verbal or physical aggression, then the IEP can also include a behavioral modification plan, and that would come with a behavioral interventionist, and that is what I do. So behavioral interventionist works one-on-one with a student that has an IEP and a behavioral plan, and the goal is to replace behaviors or extinguish them altogether. So the behavioral interventionist would go and take data. They would take data on the frequency and the duration of the behaviors. They would look at the ABCs, the antecedent, what happened before the behavior. They're going to look at the behavior. They're going to look at the consequence, what happened following the behavior. They're going to take all that data. They're going to bring it to a board-certified behavioral analyst. That analyst is going to put all the data in, and they're going to make a behavioral intervention plan. So if you click on the link, you'll be able to see an actual behavioral intervention plan that one of my students at my school follows. So if you go on there, you're going to see the problem behavior, which is verbal aggression towards staff and peers, physical aggression towards staff and peers, elopement, so leaving the designated area that they're supposed to be in, task avoidance, so anytime there is a task that they don't want to do, such as their English paper in class, or they're gonna elope. And so you're gonna see the offset, which is when it ends, and the onset. So the student ranges from 1 to 45 minutes between onset and offset, and it averages a few times a week. So the goal is to get those less and less. So to get the offset to be less. So we want to go from 45 minutes, to 5 minutes, and then eventually we want to extinguish that altogether. And so one way we do that is a lot of trying to teach replacement behaviors. So a lot of times if a student is struggling in math, instead of asking for help, right, for a child with ODD or different behavioral disorders, a lot of time it's going to come out as aggression. So aggression towards the teacher, aggression towards other students, eloping out of the classroom, all because they're trying to avoid this. So our goal is to teach them coping skills. Like, hey, you don't want to do this? Just say you don't want to do this. That's okay. Or you need a break. Ask for a break. So teaching them that there are other ways to go about that than aggressing. And so we do that a lot with positive reinforcement. Whenever they're doing something that is not the problem behavior, so whenever they're engaging in anything else. So if they're coming and they're sitting in their seat, great job, like coming into class, great job asking for a break. And so the goal and the hope is that they're going to start seeking that positive reinforcement versus the negative reinforcement that they're most likely used to. And as you can see on the bottom, there are goals. So by 2021, the student is going to engage this many times in the problem behavior, and the offset is going to be this much. And so it can be a long process. Some children respond better to this than others. This is used in ABA therapy, which is this applied behavioral analysis, which started as a need to treat children with autism. So it's always not 100% effective. We know that there are other things going on with these children, depression, anxiety, and there's a myriad of other things. And so it's not always 100% effective, but it is a start in treating that. So parenting education and parent-child interaction therapy is also critical. That is provided by psychologists and psychiatrists. We know that early intervention is key. Treatment is very important. There is a study with 70% of adolescent suicide victims met criteria for both a mood disorder and an externalizing disorder such as ODD. So we know that treatment is critical to the adolescent to grow up to be healthy and functioning. And if we look at it from a biblical perspective, we know that it can be hard, right, for the parents or for the loved ones that have to deal with these kids with ODD and all of their behaviors. But we know that staying calm is critical. You don't want to match anger with anger because that never makes it worse. That never makes it any better. And so if you look at Proverbs, it says a soft answer turns away wrath, but a harsh word stirs up anger. And so it's just important that these kids are trying. They didn't ask to have ODD. They are struggling just as much as the person helping them is. And I have, in my work, I see so many kids who are like, I just wish I could calm down, or I wish I could turn my brain off. And you see the struggle of them trying their best. So it's important to remember that underneath all of that behavior, there's still a child who is struggling and who is hurting. And so loving them and just giving them that positive reinforcement is going to be key in the long run to treating them effectively.
There's still much research needed for ODD. For girls, there's very little research indicating the prevalence of them, if it's prevalent in girls, or maybe if it manifests differently. As we covered in the history, it has been typically just studied within boys or diagnosed within males. Perhaps there's more emotional manipulation and less physical aggression when it manifests within girls, but there's just no research to guide us on that. As we covered in the history of ODD, there has been recent growth and changes with the diagnosis, meaning there's a lack of longitudinal studies addressing treatment or cases throughout a lifetime. The neurological discoveries are recent, and it is as of yet unclear whether ODD causes the thinning of the gray matter or if it is the other way around. We heard Jennifer already tell a little bit about her work with adolescents with ODD and how it impacts her everyday life and how it impacts the lives of the children that she works with. Understanding this disorder has a great impact on us as future counselors. It helps us to identify in our personal lives with our families and friends, and then advise on a course of action or encourage testing if we see it within our families. Being able to understand ODD will be a great benefit for our futures as counselors in identifying and treating the disorder, especially since it's both a child and a parenting concern. We can understand that a successful approach to treating ODD will include collaboration between parents, the child, and schools. Additionally, researching this topic has given us confidence to research other disorders that we may come in contact with. Thank you for watching our presentation. If you'd like further information on ODD, further reading can be found on our list of references.